welcome back to the 20th episode of the UFTM podcast. My name is Fabian and sorry for the long radio silence. Today we are recording from Scotland in the United Kingdom, and the guest that we brought to this podcast today is someone some of you might know from the 2026 UFTM pre-conference. I'm here with Dr. Michael Blackmore in Scotland. Thanks, Michael, for taking the time today.
Thanks for having me.
Many of our listeners, most of them are young GPs in their first 5 years of training or just after having specialized. Some of them might have listened to your speech in Paris, but a lot of them might not have. Can you give us a quick introduction what your speech in Paris was about?
Yes, my speech was about how, as a young doctor, I crashed and burned using drugs especially, but alcohol as well, because I couldn't deal with the uncertainty of medicine. I couldn't deal with that analysis paralysis of the decisions you had to make. I've also got a history of trauma in the past, adverse childhood events, which made me wired and fired and predisposed to addiction. So when I got given the keys to the sweetie cupboard, I would use various drugs to help soothe that existential angst I had at my work. I thought I'd found the perfect way of coping with medicine and the stresses of medicine, but it grew arms and legs, and eventually I suffered the consequences. Ever since I crashed and burned, I've been trying to rehabilitate myself and help young doctors realise that it's okay to make a mistake, but you can still have a career afterwards if you try and face up to it.
Michael, thank you so much for sharing this story with us today. When I first listened to you in Paris, I was very taken aback that a lot of the messages that you shared actually resonated with a lot of young GPs, myself included. And you speak about this uncertainty in postgraduate training that you also experienced. Can you tell us a bit more about this uncertainty between professional clinical work, the uncertainty in medical decisions, the personal difficulty to find a balance between all the different responsibilities, and your coping strategy back then? You changed, but how did this feeling in training trigger the addiction story that you're talking about?
Okay, let's take it back to medical school. When we're in medical school, we just don't know what we don't know. And then we eventually become doctors and we're now let out onto the patient world, but we know what we don't know, or sometimes we don't know what we know. And that's a very difficult situation for someone who's a little bit obsessive, a little bit compulsive, as most of us are, to get into medicine. So I couldn't deal with that uncertainty, and I found abnormal ways of coping with that. I do try and tell people there are better ways of dealing with it. I didn't know how to tame the chaos of my thinking sometimes. I'd be dealing with patients and I'd be like, do I do this thing or do I do this thing? And I couldn't work out which one to do. So sometimes I'd do nothing, and that was worse for the patient often. I felt less than compared to my peers. I was comparing their exterior with my interior, and my interior was a whirlwind of emotions a lot of the time. I just struggled with fitting in as well. I struggled fitting in with other doctors, with society, with patients sometimes. I've got a very busy head, and sometimes I would do silly things, make silly mistakes, and beat myself up for ages afterwards. I had to learn how to deal with that. But once you've got a bit of insight into what makes you tick, then you don't have to make the same mistakes over and over again. Does that answer your question?
It does, yes. And I think it also relates a bit to this feeling many of us might know from a concept. It's called imposter syndrome, where you feel you don't really belong and you feel everyone else around you has sorted it out in a better way, or also portrays it maybe in a better way. But then when you look inside yourself, you have this feeling of insecurity. You have the feeling, especially in medicine, where there's a lot of competitiveness in your studies. How did this feeling lead you into drug abuse? Or was it not related to
No,
this feeling?
It definitely was related. I started using drugs and alcohol at school, and it changed the way I felt inside. So instead of being an outsider looking in, trying to be in with the in crowd, I would get out of my face, off my tits, and then people would be like, oh, look at you, you should have seen you last night. And at least people were talking about me, whereas before they hadn't. So, I felt like I continued that through medical school and became one of the in crowd, one of the guys to go out partying with. And that followed me through because I hadn't changed as a person. Just what I did as a job or a role in society, from students to medical students to doctor, had changed. I didn't change the way I acted like many of my peers did. My drug use grew arms and legs. there was a little old lady who came into accident and emergency with a fractured neck of femur. And I gave her a very small amount of morphine. And she was like, "Oh, that's lovely, doctor." And then orthopedics took her up quite quickly to the ward, and I had this leftover morphine. And I'd experienced morphine before, and I knew it made me feel calm and relaxed and gave me a nice warm hug. And I was struggling with all the emergencies in the department that day and the chaos. So I made the stupidest decision of my life, injected that medication, and then floated through the rest of that shift. And I thought I'd found the ways and means to deal with the stresses of medicine. I thought it made me a better doctor. I thought it made me like Keith Richards and music. You know, he takes drugs, he's a better musician. I thought, I'll take drugs in certain amounts because I've got some knowledge about this and I'll be a better doctor. Of course I wasn't, but I deluded myself into thinking that this was the way I could deal with the stresses rather than crashing and burning and going off sick.
So essentially, the way you describe it, the step into drug use was to find a way to distance yourself from the stress that you also experience in yourself, but also the stress that was put onto us by the system of medicine, especially in medical school, where competitiveness and also peer pressure and belonging into the social group or not belonging into the social group then kind of translated into the professional world, where identification as a doctor, so everyone sees you as the doctor who is in charge, but you don't really feel that you have the grip on anything that happens. I think many of us know that feeling from their first shift in the emergency department. Any kind of work in clinical practice where you are never 100% sure what you are doing. You use drugs as a means to create a bit of distance between yourself and the responsibility. And it sounds like it was good for a little bit. You found the sweet spot. When did you realize it wasn't a sweet spot at all?
Oh, it took me a long time to realize that. So the trauma in my childhood, I'm not going to go into, but there were adverse childhood events. So I was constantly anxious and my nerves were jangly and jittery. And I put a mask on in lots of situations. But then when I found alcohol and cannabis at school, that helped for a while. And then at medical school, I moved on to ecstasy and speed and other drugs. And that helped for a while. I was medicating my madness. But then when I had the options of using opiates and benzos at medical school, that really helped. But then that progressed, and it was a stepwise progression into worsening drug use more and more and more to make me feel normal again. And at the end, it was stupid amounts of drugs that I was recycling, I was stealing. And I was at risk of killing myself. I was going to be another drug-related death statistic if I didn't do something different. So one day, after using a load of drugs and trying to take my own life and messing it up again, I realised I had to do something different. So something changed there. But it took a long, long time to get to that stage. It was over about 15 years. It's very insidious, very progressive, and I just didn't see it happening. There was this juxtaposition that I'm a medic, I can't be an addict. I was different to all those other addicts out there. I was using it to help cope with the stresses of the job, my life, etc.
So in a way, what you're describing is, because also all the different substances, you became quite an expert on what all the different substances can do. And it sounds like you used them very specifically for that purpose. You used some of them maybe to quieten your mind. Others you used as performance-enhancing medication. And that's something that is very common until today in medical school, where people think their self-confidence is very low and they think they need to perform better. There's a lot of pressure. And then at the end of the day, they can't fall asleep. The lack of sleep leads to not being able to perform or concentrate during class, and then this kind of translates into your social life, and then there's a lot of anxiety that comes with it. A lot of students report these type of feelings, and the way it sounds, the drugs that you used were a response to those very diverse and very extreme feelings that happened within one day.
Yes, totally. When I felt down, I wanted to feel up. When I felt up, I wanted to feel down. When I had it, I didn't want it. When I didn't have it, I wanted it. I wanted to change the way I felt inside. I didn't want to just sit in the here and now and accept where I was at that moment. I had the opportunity to change things. So I had all these drugs available to me, but sometimes when a drug became available to me through work, I would develop the symptoms that that drug would treat. I'd managed to steal some diazepam, and then I'd start feeling anxious. Of course I was anxious, I was stealing diazepam. And so like, oh, I can take the diazepam to treat this symptom that I've now developed after stealing the drug. It was crazy. There wasn't cause and effect. Everything was just all mushed up together in this insidious, progressive disease that I had. I did see it as a moral failing. I thought it was a lack of willpower. I realise now it's not. It is a disease. It's a disease of dis-ease. I felt uncomfortable in my own skin, and I had to change the way I felt.
Can you explain that to our non-English speakers? What do you mean with dis-ease?
I tell people in my talks, it's not a moral failing or a lack of willpower. It's a disease. It's a biopsychosocial disease where the brain is kind of hijacked. It's a disease of dis-ease. You feel uncomfortable in your own skin. It's a disease of more. Once you pop, you just can't stop. It's a disease of perception. The way you see the world isn't the way the world always is. I sometimes see the world through abnormally tinted glasses. And the way I see it isn't the way that everyone else sees it. I have my own weird negative perception. There's this 80-20 rule about our thoughts, and 80% of our thoughts are negative in nature. Mm-hmm. At the time, mine were more like 99% of my thoughts were negative in nature, and 1% was the anticipation of scoring drugs. That's a very difficult place to live. By the end of my using, I just had no hope. I tried various ways of stopping. Not great ways, just my ways.
What kind of ways did you try?
I tried a psychologist for £90 an hour.
Was that in medical school?
That wasn't at medical school. At medical school, I went to see the doctors, the GPs, over and over again, trying to get more painkillers for my knee pain, cocodamol, dihydrocodone, tramadol. I didn't have knee pain. I just needed to soothe my existential angst with some sort of opioids. And this was the best way I could get it at medical school.
Were you approached by the doctors for the painkillers you were asking for, or did they just give it to you?
They just gave it to me because I was a very good liar. I could say the right things to get the medication I wanted. Since then, over the years, I've worked in the addiction field and I've worked in the prison service, and patients know what buzzwords to say to get what they want. Oh, my friend gave me a drug beginning with P, pregabalin. That's the one, doctor. No, you're not getting it. So there's ways of manipulating, especially young doctors, to get the drug of choice. Drug of no choice. I had no choice over this. I didn't realise what I was doing and why I was doing it. I thought at the end I was a bad person trying to become good. But I wasn't. I was a sick person who needed to become better. And I needed people who had the same disease of dis-ease as me to get better.
At the same time, drug abuse, alcohol abuse, I mean, you speak very openly about it, and I applaud you for being on this podcast and speaking to us about this. There's a lot of stigma around drug abuse, especially in medical school, or probably even more so when you are in training or when you are a young doctor or a GP or, well, any sort of doctor, especially also in emergency medicine where it's probably common. Was that something that your peers or the university or also your GP training, was that something that was addressed that you could relate to?
There is a lot of drug use amongst our peers. We have a 10 to 12% career risk, just like the normal public, of using something to help soothe our anxieties. Whether that's alcohol, especially expensive malt whiskies because we've got disposable income, whether that's sleeping tablets, Valium, diazepam, and we can use that to help us quieten our monkey minds because we are overthinkers. We are perfectionists. We do obsess and compulse over certain things. A lot of people in medicine are now realised to be neurodiverse, autistic. Some doctors have ADHD, and they have been medicating their disease process with drugs to try and help them cope. I mean, we give people with ADHD licks dexamphetamine, speed, to try and help them deal with life. So that's probably what I was doing. I was probably trying to medicate my neurodiversity. But since then, I do these talks to try and reduce the stigma associated with it. I'll tell my story whenever I can because I do believe my addiction was my superpower. My recovery from addiction is my superpower. But talking about it helps open those conversations, hopefully. And hopefully someone listen to this when they next deal with an addict, patient, or family friend, or colleague. Will treat it with a little bit more compassion and say there is a way to get through this, you can recover, and you can go on to have an excellent life afterwards.
When you speak about approaching someone who might have an addiction, you speak a lot about compassion. Is that something that you experienced early on when you spoke about your own addiction, or was it a difficult step to do? When I think about a medical student or a young doctor who comes forward and says, well, I think I might have a problem. In medicine, we have a culture often that makes it maybe very hard to speak about those diseases that affect your mental capacity in a way. And I think maybe some of our colleagues that might listen to our podcast now think, well, maybe this applies to me or applies to someone I know, but I might not have the courage that you have.
I found that when I was open and honest with the place I was working at and getting my drugs from, they sacked me straight away. My GP was excellent and referred me to rehab and helped a lot. The GMC, who is our regulatory body in the UK, treated it as a health condition rather than a bad doctor situation. They put boundaries in place to stop me from using, but it really helped. Since then, I had problems getting back to work initially because people didn't want to take on an unwell doctor who might relapse. But then I got my perfect job. I was applying for jobs that I didn't want and not getting, and I was really upset that I wasn't getting these jobs I didn't want. But then I saw my perfect job come up, and I was open and honest in the interview. I was like, this is where I have been, this is where I am now. I think I've turned a negative into a positive. I think I can be of benefit to you guys, and they gave me a job. And I'm still working in the same area. I've worked in the addiction service and the prison service. I've taken on a partnership in a GP practice. I'm recruitment and retention lead. I do all this other stuff. I'm chair of a Scottish faculty. I do all this great stuff because I'm trying to make up still from old mistakes, I guess. 17 years down the line, clean and sober, and I still have that less than feeling sometimes. Some of my patients have stigmatized me and referred me back to the GMC. Did you know this doctor is an addict? The GMC are like, yep, he's fine. He's got insight. He knows what he's doing. We're happy with him. Those patients are usually the ones that want pregabalin or tramadol or stuff that they've been overusing. I've had so much positive feedback from the talks I've done. I've had so many doctors come up and say, I've got a friend, I've got a situation like that. I tell my story to medical schools, and I've had several medical students come up and tell me they're misusing ketamine. That seems to be the big one at the moment, to try and switch off their heads. Cocaine is making a resurgence.
Why do you think that is?
I think it's just availability and the cost is going down. Whenever I've got a patient in front of me who's saying they've got an addiction problem, some of my patients are now seeking me out because they've seen some of my talks or me on the telly. And I say to them, you've probably got low self-esteem, low self-confidence. You probably feel judged and criticised, but you're your biggest judge and critic. You probably do other people's thinking for them. I bet they think this about me, how dare they? You probably overthink things, overanalyse and catastrophise. You've got a really busy head, and when you use drugs it calms it down for a short while, but then it comes back with a vengeance. So that's that empathy, that's that sort of like identification you were talking about. I had a guy recently, I said that to him, and he started crying and he said, can you see inside my head? So there's that identification. We started getting some rapport. I'm asking him whether he's getting counsel or posh or prop cocaine. There's a difference. And he said, oh, it's posh. I ask him how much it costs, how much he's using. I'll tell him, sort of, that's a lot of money. What do you do for a living? I'm not working. Well, then are you selling or stealing or selling your body? And it's like, well, I'm not selling my body. So are you selling it or getting high in your own supply, or are you stealing? So, and it just opens up so many doors when you have that rapport with the patient.
Yeah. Because it makes it more relatable.
Yeah, and I tell them, I'm not judging them. I'm not criticising them. I'm trying to sort of get to know where they are. And then I'll try and bring in some recovery stuff. And like, well, people with the same situation as you go to these sorts of places and seek help from here. And I'll try and signpost them to all these different areas that helped me or have helped my patients that I didn't need at the time. There's so much out there that people can use.
It's so wonderful hearing your story and also learning from the experience that you made with all the recovery that you've gone through. Can we go back to this probably very, very difficult time when you decided, okay, I'm going to speak to my employer about this. I have a problem. I've realized my problem. And then you lost your job. So back then, obviously, you didn't know that this was going to end up on a very wonderful journey of recovery, ending up with you being a faculty chair, being a partner at the GP clinic. Back when you went to see your employer and realized, I'm going to approach my employer about a problem that I have, which is probably going to make me lose my job, my career, something I've worked with for maybe a decade, very hard. How did you make this very difficult decision? And if you see someone now who hasn't got this insight into a wonderful life that is ahead of them, how do you support them in making that choice? Or is that the best choice there?
Okay, so I was working in out of hours down in England, several weeks at a time, then coming back to Scotland to switch off. I'd always come back with gastric flu because of the amount of opioids I was injecting. I used so much and almost died a couple of times that I went off sick with stress, anxiety and depression. I didn't tell them it was drugs, that was the problem. I didn't tell occupational health that I had a problem with drugs, that was my coping mechanism. I was off sick for quite a while. And then I went back to work thinking I'd beaten it and then relapsed 15 minutes before my shift even started. I saw another renal colic that needed some pethidine and almost died again. So I went off sick again, self-reported to the GMC, which not many people do. They treated me very fairly. And then when I felt like
How does that work? You just call them?
I sent them an email. I was like, this is the situation I'm in. I'm doing stuff about it. I've been to the practitioner health program. I'm going into rehab. I'm not going to work for a while, but, I felt I had to let you know. And that worked really well for me. That
How did
honesty.
they reply?
They said, right, we'll open a case on it. And then there was a hearing where I had medical indemnity support. The insurance companies that you pay insurance for to help you in situations where either a patient's suing you or you've made mistakes. And it was really positive. The lovely thing is that the person who came from the medical insurance company, at the end, she said, I don't often do this, but it's my anonymity to breach and I'm in recovery as well. So it was the right person at the right time to help me.
Does that make a difference, the people that you met alongside this journey?
Yeah. Some people I've met once, they've helped me greatly, and I've never seen them again since. Is there some sort of higher power, fate, kismet, destiny, underlying vibration of all living things in the universe, putting good things in my way? I don't know. Einstein says you've got one decision to make. Do we live in a hostile universe or a friendly universe? I used to think we lived in a hostile universe. Now I'm coming to believe that we live in a friendly universe and good things happen for a reason. Bad things still happen, but they don't have to cause me to go back the way. I don't have to take that Buddhist second arrow. The first arrow is when something bad happens to you. The second arrow is when you react abnormally and make things worse for yourself. And I was doing that. So I lost my job, and it was probably a good thing because it meant I couldn't go back to the way I was and had the ability to steal drugs again. So when I did get back to work, I was honest, open, upfront, and that put barriers in place so I couldn't go back to the same old ways of doing things.
You also said in the time of your recovery, you applied to many jobs you didn't want. What did you mean by that?
I was applying for jobs, say 2 days a week as a GP, as a retainer, like ladies coming back from maternity leave. And I didn't want those jobs. I wanted a full-time job. But those weren't the ones that were being advertised. So I'd go along to them, was open and upfront. And they were like, no, we don't want you in our practice. That's not the sort of doctor we want. We don't want to be a GMC supervisor to you. We don't want to have that hassle. We want a good, clean doctor who has no problems. So I was a problem doctor. But when I went to the job in the area I still work in now, and it was addictions and prison work, they saw that my history, my lived experience, could be a positive. That's the way I sold it anyway. And it has been. I've told my story every year to the young doctors in the hospital and always gets excellent feedback just to say these are the sort of things to look out for in your career.
So what are the things you should look out for in your career?
Can I just tell you what I do in my life to try and make things easier? When I wake up in the morning, I try and meditate for at least 15 minutes.
What does that mean?
I try and quieten the monkey mind because when I wake up, my head's going off like fireworks. I try and sort of calm myself down. And I find that if I meditate, I'm more productive through the rest of the day and less reactive to situations. If I've got a really busy day, however, I'll try and meditate for 30 minutes because that way I will calm myself down a little bit more. There's a lot of good research about meditation. I try and make sure I've got an airlock to my day, to my work. So I've got 20 minutes in the morning and 20 minutes after work where I can just switch off and I don't have to think about anything. I don't have to take my work home or my stresses from home to work.
So that's your commute to work?
That's my commute to work. I try and keep a gratitude list, write down all the things I'm grateful for. There's a lot of positive research about if you write down what you're grateful for, then you won't be so negative in nature. I try as best I can to switch off my busy head at work and try not to interrupt too many times because I'm really bad for that. I try and adopt a different persona. Sometimes I'll still jump in too quickly when someone's still talking. Some of my patients have called me abrupt and arrogant, and I'm not. This is the way I am. I'm neurodiverse. Patients put doctors on pedestals, and sometimes I think they dehumanize us, think we should be perfect, and we're not. We're all human.
Thank you for sharing that. Michael, we have a little game prepared in this podcast. I know I told you a bit about it beforehand. So it's adapted from a German podcast. It's called an A and B game. And the idea is to pick as quickly as you can one of the two words that I give you. And don't think too much about it. If you want to discuss any of your choices, let's do it afterwards. And then if something doesn't really give you a decision straight away, you can always say skip. Are you ready for our little game?
Skip.
Scotland or England?
Scotland.
GP clinic or hospital?
GP clinic.
Coffee or tea?
Tea.
Morning or afternoon clinic?
Morning.
Research or clinical work?
Clinical work.
Teaching or mentoring?
Mentoring.
RCGP or Wonka?
RCGP.
Lecture or workshop?
Workshop.
Prevention or treatment?
Prevention.
Acute care or chronic care?
Chronic care.
Family medicine or public health?
Family medicine.
Leadership or teamwork?
Teamwork.
Medical student or GP trainee?
GP trainee.
Speaking or writing?
Speaking.
Podcast or video?
Podcast.
Evidence or experience?
Experience.
Face-to-face consultations or telemedicine?
Mixture.
Mountains or seaside?
Mountains.
Edinburgh or Glasgow?
Oh, both. They're both great.
Glasgow or Stirling?
Sterling.
Rugby or football?
Football.
Summer or winter?
Winter.
TED Talk or conference lecture?
Conference lecture.
Coffee break or lunch break?
Lunch break.
Early bird or night owl?
Early bird.
NHS or private practice?
NHS.
Fee for service or capitation?
Capitation.
Paper notes or electronic records?
Electronic records.
Walking or cycling?
Walking.
Book or movie?
Movie.
Home cooking or going out to a restaurant?
Restaurant.
Sweet or savory?
Savory.
Sunrise or sunset?
Sunrise.
Train or plane?
Train.
Small meetings or large congresses?
Small meetings.
Listening or talking?
Talking.
Family medicine or addiction medicine?
Family medicine.
Clinical guidelines or clinical intuition?
Intuition.
Academia or clinical practice?
Clinical practice.
Faculty chair or being a partner in a GP practice?
Partner.
House visit or practice appointments?
Practice appointments.
Stethoscope or ultrasound?
Stethoscope.
Family holiday or conference trip?
Family holiday.
Well-being or success?
Well-being.
Inspire or be inspired?
Inspire.
Future or tradition?
Future.
Thank you. 55 word pairs. Any specific pairs you want to talk about? I saw you skipped Edinburgh or Glasgow.
I love going to Edinburgh. That's where I did my rehab. 12 weeks in Edinburgh, going to all the meetings around there. I still go there every month for a doctors and dentists meeting.
What's that?
So the British Doctors and Dentists Group is kind of like AA for only doctors and dentists, so they can talk about the professional issues that they experience as well, that they may not be able to talk about in AA or CA, Cocaine Anonymous, or NA, Narcotics Anonymous.
Is it always abuse related?
It's either alcohol or drugs, yes.
Right.
Yep. It's not anything else. And we always have a constant stream of doctors or dentists who need help with their coping mechanisms that have gone abnormal.
When you spoke in Paris, you spoke about something that I found really interesting, and you spoke about addiction doesn't necessarily need to be substance related. There are many different other types of addiction that also doctors might be more prevalent, or might be more prevalent in a doctor's population. What other types of addictive behavior, let's say, have you seen in colleagues or in medical professionals?
Mobile phone addiction, social media addiction, gambling addiction. The doctors that come to our group are usually drugs and alcohol. I did meet a sex addict who family had been decimated by his low self-esteem, which he tried to boost it by having intercourse whenever, wherever. There are many other types of addiction, including food addiction. There's Overeaters Anonymous. And we all have a tendency to find different ways of soothing ourselves that can go wrong.
Is there a commonality between all these addictions in medicine?
Yeah, all of them are human. I think that doctors struggle with the job sometimes, with the lack of funding, with the workload, and try and find an easy route, a quick route to soothing these anxieties. And that's where addiction can sometimes come in.
When you think back to your own time in medical school and also postgraduate training, and when you think back to the large crowd that you saw in Paris during the pre-conference, is there anything that, if you were able to travel back in time and tell your younger self or younger colleagues nowadays, is there something you would tell them if they struggle with addiction? Any of the type of addictions you just mentioned?
Yes, ask for help early, get some insight into it, meet people who've been there, seen it, done it, and come out the other side, learn how they did it, and follow their example. Don't try and do it yourself. You just cannot do it yourself. Be honest, be open-minded, and be willing to do whatever it takes to get better. Put your recovery first, and everything else, and I mean everything else, seems to fall in behind it. I didn't expect to be doing what I'm doing now. I am living a life much better than I could have imagined because of doing the work in early recovery and doing the ongoing continued work, which is nowhere near as intense now, but still needs to be done to help me not go back the way.
Thank you very much, Michael. I think this is a very valuable message that you shared with us. Thanks also for taking the time on your own Sunday, so we're cutting into your quality time. Thanks so much for spending time with us today and sharing your own insights and also your personal story with us. I hope a lot of our listeners can relate to some of the messages and very important learnings that you shared today with us. Thank you so much.
Thank you. Can we just go on to the last questions, because those are quite important?
Yes, sure.
You sent me a list of questions, and you said, as chair of the RCGP West Scotland faculty, what do you currently see as the biggest challenges for general practice? I'd like to answer that.
Yes, please, go.
So, I think there are 3 things we need to work on: workload, workforce, and workplaces. Often in our workload, we are overwhelmed with the amount of medicine we've got. It's been so much more complexity over the time I've been a doctor. I believe that there is also a shift from secondary care onto primary care now. We're being asked to offer more community medicine, care in the community, but we're not getting the funding that comes with that.
Mm-hmm.
Workforce. We are losing doctors to retirement earlier and earlier. We're losing young doctors like yourselves to Canada, New Zealand, Australia. And this means that the people who are left have to do more and more of the work. We need to offer better infrastructure in our workplaces, like IT. We need electronic prescribing in the UK, and we need to offer better buildings with more capacity. At the moment, we've got physiotherapists, mental health nurses, pharmacists in our buildings, but they're taking up rooms that could be used by trainees. We could be training more doctors. In the UK, each full-time equivalent doctor carries about 2,200 patients. We want to get that down to about 1,000. Therefore, you can offer continuity of care with the same doctor all the time. Reduce the amount of times you need to see the doctor, reduce the admissions, reduce the investigations, reduce the treatments you get, and improve your quality of care. That's what we need to do. You also asked, what advice would you give to young family doctors just starting in their careers? Kind of alluded to that earlier, but you need to find your tribe. You can't do this alone. You have to realise that good enough is good enough. You are a very expensive trained diagnostic and treatment tool, and you can do amazing things. People will try and criticise you at some points in your career, and you have to rise above that criticism. I don't accept criticism from anyone that I wouldn't take advice from.
It's a very, very powerful message, I think.
Yeah, no one can make you feel inferior without your permission, and I try not to give people my permission, no matter what they say. To thine own self be true. You have to do what feels right for you. If someone's coming in looking for treatment they don't need, maybe addiction medications or something else, sort of say no, or say not at the moment, let's explore this further. Look at the pain points in your day and try and tame that chaos. Take away those pain points if you can. Change what you can and accept what you can't. Realise that medicine is much better done when it's relational medicine rather than transactional. Too many doctors are being forced into doing very quick on-the-day appointments, quick fixes, whereas in your questions about preventative medicine, I chose prevention because that's going to help our patients a lot better. And the last thing, general practice is this triangle of access, quality of care and funding. And we need more funding to offer better access and better quality of care. So those are my final points before you shut me down and end the podcast.
Maybe one last point, because when listening to you, you spoke about finding your tribe, but you also said you applied to quite a lot of jobs you didn't want, and then you found this one job which essentially combined something that you were very knowledgeable about because of your own personal history, but also because you've been there, you've done that, and over the time after your active addiction, you've developed special interest, I guess, in a way, in addiction medicine. You sub-trained in special addiction medicine, and you also added this to your GP portfolio. you. So you use the special interest, and it sounds like the special interest that you chose kept you going through your, I don't want to say normal GP work, but it kept you going through your GP work. And I think a lot of people have that inkling, they have a special interest, or they have something that is connected to general practice, and using that special interest as part of their career is a very meaningful way to the younger generation when it comes to workforce retention, which is something that was very dear to you.
I think the evidence shows that if you have a special interest, a portfolio career, you're going to be happier in your job and you'll stay in it longer. You'll be less likely to change jobs. So yes, it does retain doctors. There is some evidence that says if you have some research in your job role, you'll be able to recruit doctors easier. So, sort of try and put that out there. I do a lot of work with the first 5 doctors and the trainees. We've set up a meet and connect support bubble. So we try and get a little bit of a community going, and if they feel part of a community, they'll be less likely to leave the area. Wednesday just gone, we had another meet and connect group. And we weren't talking about cardiac failure or diabetes or respiratory. We went to my local scout group and we threw axes and we fired arrows and we built a Da Vinci bridge and we did backwards cooking, and it was great. And everyone was just so enthused and chatty. We had people come from outside our area coming to have a look at what we were doing. You need to find your tribe. You need to find people to network with and share some of the issues that you have as you go through your career. You can't keep it all bottled up inside because you'll burst. So that's what I would recommend more than anything. Try not to go over bad things that happen too much. Try not to make those neural pathways motorways. But, sort of share it, unload it, reframe it, and then move on.
I think this is a wonderful message for us to go home with. Thank you very much, Michael, for your time. Thanks for adding those questions that I forgot. And thank you for the Sunday afternoon that you spent with us. Thank you very much.
Hugs, not drugs.